100 kilometers away from my hometown here, from the sunny island up north. Yeah, it's a great pleasure to talk about the potential impact of early detection in patient outcome, but particularly focus on GI cancer and later on esophageal cancer. GI cancers are very common. They represent about a third of all cancer mortality and about a quarter of all cancers. And you all know that colon cancer is the commonest, followed by stomach cancer. Stomach is in great decline in incidence thanks to refrigeration and H. pylori eradication. Colorectal cancer remains a leading cause of cancer worldwide. Looking at luminal GI cancers, there's a common theme which is important to understand in terms of early detection and prevention. That is the fact that all these cancers are preceded by pre-malignant conditions. So in the esophagus, there's adenocarcinoma and squamous cell cancer. Adenocarcinoma is commonly preceded by Barrett's esophagus, linked to gastroesophageal reflux, and squamous cell cancer preceded by dysplasia. The stomach is also characterized by a premalignant condition called atrophy, intestinal metaplasia. I think we are all familiar with the fact that colon cancer is preceded by the adenoma. So there is a possibility to intervene with early detection. And I think we are all very familiar with the impact of fecal immunochemical testing in colon cancer. This is just one of the studies that has shown some improvement. This was an SC control study in the Kaiser Permanente population, where cases were people that died of colon cancer, controls were people that did not die. This is a pool of screening eligible people. And the evidence here is that having had at least one fit in the preceding 5 years impacted on the odds ratio for cancer-related death across most of the ethnicities. Interestingly, the Hispanic did not benefit as much as the other ethnicities. Colon cancer has a rather high incidence across all geographical cancer areas, but esophageal and stomach cancer have a great variability in incidence. That's the main issue here, trying to design a preventative strategies that can be applicable to all different geographical areas. So looking at the esophagus, for example, that was touched upon early on in the morning, the esophageal adenocarcinoma, top left, is typically a disease of the Western population, high incidence in North America, Northern Europe, and Australia, whereas the squamous cell cancer is typically more prevalent across the so-called esophageal cancer belt, South Asia, and Eastern and South Africa. The stomach cancer, particularly the non-cardia stomach cancer, bottom right, is highly prevalent in Asia, particularly in several regions in China. So you can see the challenges in terms of designing strategies that can be applicable to different geographical areas. And as I mentioned before, stomach cancer is greatly declining in incidence, particularly because of the refrigeration and test and treat strategy for H. pylori. But esophageal cancer, in particular, the esophageal adenocarcinoma, has a worrying trend because it's one of the solid malignancies with the fastest rise in incidence. Here in black is esophageal adenocarcinoma, and all the other lines are the more common solid malignancies. As you can see that while most of the cancers are rather stable or slightly rising, esophageal adenocarcinoma has been increasing steadily, and there is projections up until 2040 that this will continue to happen. So how can we design a strategy that can be cost-effective, applicable to the general population and particularly primary care? And obviously, we have some knowledge about what the risk factors are for esophageal adenocarcinoma, obesity, acid reflux, and obviously known Barrett's esophagus. And we also know that if you don't catch the esophageal adenocarcinoma early enough, the prognosis is pretty dismal. So this is a test called capsule sponge that was invented by Professor Fitzgerald in Cambridge. It's a pill on a string with a polyurethane capsule embedded in it. Once the capsule reaches the stomach, the gelatin dissolves. And then the sponge can be simply retrieved by an administering nurses, and on its trip back through the esophagus can collect cells, if there is Barrett's esophagus, from the Barrett's esophagus, but can also collect cells from the squamous epithelium. And the test is linked to a simple immunohistochemical test, which is the TFF3, which is a protein highly expressed in intestinal tissue. And you can see a staining for TFF3 here. And also a great variety of different cells in the H&E, including gastric cardia cells, squamous cells, and also potentially Barrett's gland cells. The test has been proven to be sensitive and specific for Barrett's esophagus in a number of prospective cohort and case control studies, and also deployed in the UK in a previously published randomized control trial on nearly 14,000 people with history of reflux, where we compared the intervention on the right against standard of care. If the people that had the intervention had a positive test, they had a confirmatory endoscopy to see if there was an underlying Barrett's esophagus. The results were pretty clear. So the intervention on the right was linked to a tenfold increase in the rate of premalignant condition, Barrett's esophagus diagnosis, so the odds ratio 10.2 compared to the usual care. But also interestingly, if you look at the intervention arm, there were a number of premalignant dysplastic conditions and also stage 1 cancer that were diagnosed, whereas in the usual care on the right, there were no stage 1 cancers, no dysplastic premalignant stages. So there is a potential here not only to increase the detection rate of the pre-malignant condition, but also the early neoplastic changes of the esophagus. And as a result of that, a number of clinical guidelines do recommend the use of capsule sponge test as a case finding in people with reflux disease and other risk factors. So knowing whether you've got Barrett's esophagus, does that offer an opportunity to prevent mortality from cancer? This is a study that we did also in Cambridge, where we looked a 20-year period, the cohort of 1,000 patients with Barrett's esophagus, and over these 20 years, about 10% of them progressed. I'm not sure whether you can read, but the bottom line is that there were very, very few cases of advanced cancer detected. Most of the neoplastic changes were either high-grade dysplasia or T1A cancer. And we looked at the mortality by esophageal adenocarcinoma in people diagnosed with cancer on surveillance. That was very low, 6.3. Usually, 80–85% of people with esophageal cancer will be dead at 5 years. So that was a good confirmatory data that if you initiate surveillance strategy once you have a premalignant condition diagnosis, you can impact on patient outcome. So that led to the currently ongoing BEST4 study, which is a randomized controlled trial, 2-to-1, usual care versus intervention, with the aim to enroll 120,000 people with acid reflux in the UK, people with a positive test will have a confirmatory endoscopy. This is a very interesting design for us because eligible patients are, eligible individuals are recruited via text message through a company, iPlato, which has access to demographic data. And the test will be carried out in the community in 5 mobile units, moving across the country in several regions of the UK, including Scotland and Wales. We are planning to do recruitment over a period of 3 years and have 12 years follow-up data. And the primary endpoint will be a composite stage and mortality by esophageal adenocarcinoma endpoint, which means we'll look at the, the number of stage 2 or higher cancer and death by esophageal adenocarcinoma. Obviously, from a cost-effectiveness point of view, you can imagine that knowing about a large population of people with a predisposing condition who might need, according to the guideline, surveillance, this is going to overwhelm our endoscopy services. And that's clearly a possibility. We know that 60% of the people with positive tests will end up having a diagnosis and will need to have surveillance. So we did develop a risk stratification tool, in fact, based on the sponge results themselves, whereby we can not only look at TFF3 as a marker of intestinal metaplasia, but we can also look at atypia and P53. P53 is the most commonly mutated gene in esophageal adenocarcinoma, as well as in a number of other solid malignancies. And we know that if you have atypia, i.e. dysplastic cytological changes, or P53, there is a high risk of having dysplasia or early cancer in the Barrett's. We also identified 2 different categories, a moderate risk category based on demographics, like age, sex, and extent of the known Barrett's esophagus, and a low-risk category. So potentially you can use the sponge to even monitor people with Barrett's esophagus to prevent the burden of surveillance as a result of the increased diagnostic rate. And we recently published the results of our prospective trial on the risk stratification tool, showing that the high-risk categories, so 1 being the highest risk category when there is both atypia and P53, and 2 being the second highest risk if there is P53 or atypia, these people have a much higher risk on the Kaplan-Meier curve to progress to high-grade dysplasia or cancer, with the odds ratio varying between 29 and 137, depending on the category. So there is a possibility then to potentially use the same test not only to screen, but also survey and identify those that have a greater need to have an endoscopy. So just to conclude, GI cancer do account for 1/3 of the global cancer mortality. And in terms of colorectal cancer, FIT is the test that has proved to be clinically accurate and acceptable in terms of cost effectiveness for screening. Gastric cancer is steadily declining in incidence, still represent an important cause of cancer mortality. We're actually looking at how the sponge could potentially sense the luminal environment in the stomach to lead to a diagnosis of premalignant gastric cancer conditions in the stomach too. And certainly the capsule sponge is a very promising strategy for early detection of esophageal cancer, and work is underway to demonstrate the impact on patient cancer outcome. Thank you very much for your attention.